Yes, sir.
Yes. Cell injury occurs when cells are stressed so severely that they are no longer able to adapt, or they're exposed to inherently damaging agents, or suffer from intrinsic abnormalities. Cell injury can be reversible, and then when it is irreversible, it leads to cell death. So you have reversible cell injury, will be functional, but will have morphological changes that are reversible if you remove the stress or the strain or the toxic chemical that's affecting the cell, if you remove that away. Cell death occurs when the injury becomes irreversible. And there are important things, features to note that come up when cell death becomes inevitable. There are also two main methods for cell death, necrosis or apoptosis. Both of them differ in how they occur, what leads to them, and the role they play in disease and physiology. Now, what are some of those factors that can lead to cell injury? An example is oxygen deprivation. Oxygen deprivation is hypoxia. It interferes with the aerobic oxidative respiration and is an extremely important and common cause of cell injury and death. This is commonly seen, for example, in when there's a blockage of the artery or the vein supplying a major organ, right? That leads to lack of blood supply to that area. And of course, oxygen is deprived from that organ, and then nutrients are also withheld from that organ, leading to something called an infarct, okay, which is an area of tissue death. Okay, if it is reversed quickly, the cells will only become reversibly injured. But if the hypoxia is sustained until the cells are irreversibly damaged, then the infarct becomes permanent. So that area of cell death the cells there die, and then they can be replaced in cells that regenerate. Okay, it can also be due to chemical agents. An enormous number of chemical substances can injure the cells. Even, for example, innocuous substances like glucose or salt, which are found naturally in our cellular environment. If they're sufficiently concentrated, can so derange the osmotic environment that cell injury or cell death results. This can be an example of this is, for example, if you inject a hypertonic solution, that's a solution that has higher osmolar concentration than what is found in the normal body, normal cell milieu. If you inject it into a body part, you find inflammation and you find cell injury occur in that area. Another example is when there's infection. For example, when there's a boil, right? If there's a boil is, for example, an infection in a soft tissue area, the bacteria in that area continues to extract and release toxins, extract nutrients, release toxins into the environment. That leads to cell injury and, of course, cell death. Immunologic reactions, genetic defects, nutritional imbalance, physical agents like trauma. Trauma, for example, is when someone is involved in a physical accident and that results into damage. Okay, there can be physical trauma, there can be emotional trauma, but we're referring to physical trauma in this condition. Extremes of temperature, for example, if there's a fire burn, the cells first lose their moisture and then begin to denature. But of course, if, for example, cells, that are not immediately being burned, immediately, for example, the victim is given some sort of first aid, right? You'll preserve some cellular function and the person recovers. So there can be cell injury and cell death, from any of all of these causes. Now, the process usually is that when there's stress or strain on a cell, hello, can you hear me now?
Yes, sir.
Okay, sorry, I accidentally muted myself. Okay, so like I said, the normal process is that a cell in homeostasis, that's a normal cell, can go under stress and strain and adapt. And there are 4 mechanisms of adaptation. What did we say those were?
Hyperplasia, hypertrophy, metaplasia, and atrophy.
Thank you. Now, if that stress is sustained, right? If that stress is sustained in spite of adaptation, then there will be a breaking point where the cell becomes unable to adapt further, right? And then it becomes injured. Now, there are certain stimuli that just take the cell directly from normal cell to a cell that is injured. For example, exposure to toxins and chemicals, that usually results into direct cell injury. The cell can usually not adapt to such stimulus, right? So once there's cell injury, then you can have one, it can progress to reversible cell injury. But at some point, if you still do not remove that stimulus, it goes on to point of irreversibility where necrosis takes place. Now, in between all this, you can still have subcellular alterations going on, right? Now, these subcellular alterations can either be reversible or can still go, can lead on to apoptosis, where the cell eats up itself, okay? It's a natural mechanism of cell death. And I'm sure you learned about apoptosis in biology, where apoptotic bodies are formed by the nucleus, and these release toxins into the cell cytoplasm, dissolve the cytoplasm, the cell wall, and finally the nucleus, right? So these are viable mechanisms of cell death. Now, what are the kind of morphological alterations that happen in injured cells? At the level of cell injury, what you usually will observe is the cell shape that is common. The cell experiences fatty change, so there's a lot of fat infiltration into the cell at this point. The plasma membrane blebs. What I mean by blebbing is that it has extensions, but it does not break, right? It has extensions, but it does not break. If you've I think the most hilarious example would be the head of that cartoon called right? Those funny extensions on his head are like blebs, okay? Of microvilli, mitochondrial swelling is also noticed under the microscope, and then you can have dilation of the endoplasmic reticulum, the rough or the smooth, and then you can have eosinophilia, that's agglutination of protein bodies. Now, once you pass reversible cell injury, if you notice any of these features, usually you would say the cell has become irreversibly injured. So for example, if you notice that the eosinophilia continues to increase, that the condensation of protein bodies continues unabated within that cell, then that cell has, entered into irreversible injury and will most likely progress to cell death. Once the nucleus begins to shrink and fragment and dissolves, there is no going back. There is also breakdown of plasma membrane. Once either of these two shows up, then there is irreversible cell injury and cell death is already in progress. Once the nucleus begins to shrink and the plasma breaks down, there's no going back, right? Myelin figures appear inside the cell, there's leakage and enzymatic digestion of cellular content. Now for apoptosis, there's nuclear chromatin condensation as well, and then formation of apoptotic bodies. These are usually very clear to see under the microscope. They are like bags of nuclear cytoplasm, but these are formations from the what's it called? From the enzymes that have digested the cell content, and they are usually released as soon as the cell is, gone. In terms of the differences between necrosis and apoptosis in how they form, this is important. The cell size in necrosis is enlarged, is reduced in apoptosis, because essentially what you're having in apoptosis is breakdown. So the cell is ingesting itself, is eating up itself. Now, in terms of nucleus, there is pycnosis leading to karyorrhexis and karyolysis. So this is an inflammatory process through which the nuclear material is broken down until it is finally dissolved. And then in terms of apoptosis, there's fragmentation into nucleosome-sized fragments. So the nucleus in apoptosis is never fully dissolved. It is broken down into small particles and put into the apoptotic bodies that are finally released. For plasma membrane, is disrupted in necrosis. In apoptosis, they are intact, even though they may be altered, right? In terms of cellular content, there's enzymatic digestion, and this leak out of the cell in necrosis. In apoptosis, they're intact, but definitely what you find released are the apoptotic bodies that are formed during the when the apoptotic process begins, right? Like I said, the nucleus is fragmented, and then you find it's almost as if you're taking out the trash. So you find odds and ends put together in different bags, and then they break out, right? In terms of inflammation, so most often in necrosis, you find adjacent cells are affected because the enzymatic digestion that happens leak out of that cell. But for apoptotic bodies, because they are intact, there's no leakage out. Most of what you find is localized, so there's no adjacent inflammation. Necrosis is always pathologic, while apoptosis may be physiologic. It usually happens, for example, when there is genetic damage, right? This tries to explain the same thing, but breaks it down in ways you can understand better. Now, this is what is meant by membrane blebbing. You see these protrusions that come out of the membrane here. They are not breakages. They're just extensions to accommodate more fluid and whatever is going on within. But it also shows that there is stress and strain on the the cell wall as well. And then once it begins to progress into irreversible, this is chromatin agglutination. So swelling of the endoplasmic reticulum. These are the rough endoplasmic reticulum. They also lose their roughness at this point. So those black dots that you find floating within the cytoplasm are lost from the rough endoplasmic reticulum. And then you can see nuclear condensation. Nuclear materials that were visibly identical here become, non-identical, and then they're just a mash. Then you also see mitochondrion is swollen at this point. Mitochondrion is normal, here, and then you find swollen here. And then, of course, in its final throes of death, you find fragmentation of the cell membrane. Once there's fragmentation of cell membrane or dissolution of nucleus, cell death is already in progress. But from reversible injury, you can have it going back, and then the cell, once the strain and stress is removed, the cell goes back to normal, and then that's it. This is the mechanism for apoptosis. There are two major mechanisms that lead to apoptosis. One is a mitochondrial pathway, and the second is a death receptor pathway. Mitochondrial pathway is triggered by loss of survival signals, DNA damage, and accumulation of misfolded proteins. So this is triggered when there is a genetic error in the cell. And then the death receptor pathway is responsible for elimination of self-reactive lymphocytes and damage by cytotoxic T lymphocytes. Is engaged by is initiated by engagement of death receptors, members of the TNF receptor family. That's the what's it? This is what leads to toxic necrosis. Once in people who this is largely initiated, you have something called oh Lord, I've forgotten the name of this receptor. Once I recall, I'll get it back to you. So two differences in how the two pathways are triggered. Mitochondrial pathway is triggered by genetic abnormalities, loss of survival signals. For example, in starvation. In starvation, you have loss of surviving signals, and then when there's DNA damage or misfolded proteins, that also triggers the mitochondrial pathway. For death receptor pathway, inflammation usually leads to this. So you have damage by cytotoxic T lymphocytes and all. In your notes, these are followed by short self-assessment tests. Please do well to go through them. And then finally, we'll talk about inflammation and repair. I think I talked about inflammation in the last class, didn't I? Hello, class.
Yes,
Did I?
No, sir.
Okay. They're basically four main descriptions of inflammation, but 5 when you also look at the loss of function that happens when there's structural necrosis. So first is that there's redness. This is the way inflammation is usually described, especially even clinically. When you go to the hospital, they ask you, is there redness? Does the place feel warm? Is there swelling? And is there pain? Those are the 4 characteristic ways that you identify inflammation, even though we know that now clinically this is not the ways to identify inflammation, but I mean this has stuck over time. Now, inflammation is a series of reaction of vascularized tissue. That's tissue that is supplied by blood vessels, and inflammation leads to these are like steps it takes to defend against foreign substance, dispose of dying or dead tissue, or immobilize an injured area so that healing can take place, or compartmentalize injury so that it does not spread to other parts of the body. Now, it depends on the severity of injury, immune status, and temperature at which the inflammation is occurring. That's how severe it manifests. Now, there are 4 main events that takes place during inflammation. One is neurologic event, the second is hemodynamic, the third is cellular, and the fourth is chemical. All of these events may be happening pari passu, but it's important to note that they kind of affect each other and determine what the next phase of each other would be. For example, if there's injury, there's initial vasoconstriction, where the blood vessels constrict to reduce blood loss, and then gradually you have vasodilation or relaxation of the reflexive spasm that causes the bleeding to start again. Now, there are hemodynamic events as well. Now, what happens when that bleeding starts again is that it allows inflammatory mediators to move to the site of injury so that a bleeding plug can be formed, a clot or a bleeding plug can be formed. So what the hemodynamic event does is that those large cells cause vasodilation, they slow blood flow, but they also cause the coming together of leukocytes so that there's a bleeding plug formed, and then they restore homeostasis and also cause permeability changes so that blood loss out of the blood vessels is stopped. Some of the cellular events also are related to the hemodynamic events. For example, sorry, I said homeostasis in that is hemostasis. Hemostasis means that blood flow regulation, okay? Not homeostasis, hemostasis. Now, the cells that are also, helping with the hemodynamic event are also involved in cellular events. For example, circulating leukocytes, they form large cells, right? So that, for example, the basophils release anticoagulants that enable blood flow to be restored. Neutrophils, that are the phagocytes, they take up invading microorganisms and protect the area of injury from infection. Monocytes and macrophages arrive later when the hemostatic plug has been formed to ensure that it is shaped properly and the wound is covered, okay? Chemical events like histamines, for example, would be released when those cells are broken to initiate the vasoconstriction. Bradykinin and prostaglandins help you sense the pain in that location so that you also take some sort of caution about it. So they, immediately all of this is happening together. There's a neurologic event, hemodynamic, cellular, and chemical. Very, very important. This is just to explain the same things I've just said. Now, when there's chronic inflammation, there are I think about two important chronic inflammations we're going to talk about. But recurrent inflammation prior to completion of repair or resolution is what is called chronic inflammation. So before the inflammatory process finishes, there is a new and present inflammation. This is, for example, similar in for example, occurs in tuberculosis infection, right? Now, the cellular aspect is what is important to us because that's the most emphasized aspect of chronic inflammation. The macrophages dominate in this case, right? And then you have monocytes, those giant cells, fibroblasts, and lymphocytes. The reason is there's continuous damage at the inflammation site, and then they're trying to repair, they're laying new cells of fibrin, and then also trying to shape it as well. CD8 plus T killer cells and CD4 plus delayed hypersensitivity cells are also very active. Now, note that these are the cells that usually come in last to complete the inflammatory process, but they are now predominantly active because they are consistently at, the inflammatory site because of recurrent inflammation. It always leads to hypertrophic scarring. If it's on the skin, you will notice it as, very dark buildup of skin or scars in that area. And if it's internally, you may experience some cellular, some cells may come together to form caseation. For example, in tuberculosis, there's caseation either in the lungs or extra pulmonary in the infected patient. Okay, so the first type of chronic inflammation is granulomatous inflammation. A granuloma is an abnormal structure built from at least two activated macrophages adhering to one another. They can also be referred to as epithelioid cells. Granulomas may be formed with caseation. This is typical in fungal infections and in tuberculosis. It is very difficult to treat because most of what you find is that dead cells and debris are inside that caseation.
We can hear you. Your voice is.
Can you hear me now? Hello?
Yes, sir.
I hear you, sir. We can hear you.
Okay, good. So, like I said, granulomas are difficult to treat. That's why they are interesting to us. They are difficult to treat because usually you find that the dead cells and deaths have been packed together, and then those large cells now form around them and form like a reservoir of infection. And that's why sometimes infections like fungal infections and TB take months and months, aside from the fact that the organism is hard, is a slow growing organism, but because they form caseation, it's like putting a microorganism inside cheese and then trying to slice it layer by layer, okay? So you keep killing the organism, and then, those outside will go off, and then the next layer is formed. That layer also, you have to peel that layer off, on and on like that. So it's typically hard to treat when there are granulomas with caseation. There could also be granulomas with suppuration. That's granulomas that, exude pus. And this is, they're not very common. They're old diseases that have been essentially eradicated. Brucellosis and plague, they commonly have pus, and that's one of the reasons why treating those infections may be difficult. If you also have foreign bodies embedded in your body, this can also lead to formation of granuloma, because inflammatory bodies will always form around it. And that's why sometimes when they say that the body is pushing out the foreign body, but you have a lot of pus and secretions from that area once that foreign body is being removed. The second one I have removed, that's for the chronic inflammation. I think you're overloaded as it is. So let's just stick with the granuloma as a form of chronic inflammation. In terms of regeneration and repair, this is the final resolution part of inflammation. Inflammation resolves when non-structural cells are lost after inflammation, or the damaged cells have been regenerated or repaired by fibrous tissue. This happens, it's a common process that you would have seen with injury in biology. Labile cells, or cells that can replace themselves, for example, the skin, the surface layer in the intestine, that's blood cells, right? All of these can, be repaired. Stable cells, those cells that do not grow, for example, cardiac cells, may have little proliferation without injury. So if there is, for example, if there is infarction, because cardiac cells are stable, it's hard for the cells to be replaced. But once they are dead, once those cells are once a cell death from infarction, and they're removed, that's through the normal process of apoptosis, right? They can be replaced rapidly. Another example is the liver cell. The liver, if the liver parenchyma is injured, right? In fact, if you cut the liver to maybe about 1/6 or 1/8 its size, it can regrow itself within about 48 hours to its normal size within 48 hours. So that's why usually liver injury, if you allow the person to get some rest and you remove the strain, the liver recovers almost fully. Now, there are some permanent cells that are healed by scarring, for example, the brain and the heart as well. Now, the muscles of the heart during infarction, once it is injured, similarly to the brain, for example, once there's a stroke, it results into permanent scarring. So, for example, with a stroke, some blood vessels are changed. Some parts of the brain may also be permanently affected. There may be loss of movement, loss of function in some areas, and then there may be loss of balance as well. For the heart, there is something called remodeling, which can be done by, with drugs. But essentially, once there is infarction, myocardial infarction, death of heart muscles, it's usually a permanent event. Now, how does tissue repair happen? There are basically a few processes. One is fibroplasia. This is where there's formation of granulation tissue. That's new tissue is being built. There's maturation and remodeling. This is where scar tissue, that's the fibrin that has been laid down, is remodeled so that it becomes functional and replaces the dead tissue. This usually happens in repair. Now, this can also be applied to surgical wounds. If you look at surgical wounds, they heal mainly by two processes. Healing by primary intention, that means the wound was neatly put together and then healing takes place. That's inflammation happens, healing takes place, regeneration and repair by new tissues, no big scar is left. Sometimes if what happens is that the person was maybe stabbed by a bottle or something, and then it was just left to just heal like that, you'll find that the tissue, the wound heals up with a lot of scar, okay? Factors that are responsible for wound healing, growth factors like platelet-derived growth factor, epidermal growth factor, fibroblast growth factor, transforming growth factor, and cachectin. With that, we come to the end of the class. Any questions?